So I'm Stacy Lindau. I'm a faculty member in the medical school, specifically the departments of OBGYN and medicine. I have an area of research that fits well with my role as a gynecologist and relates to human sexuality, and we're not going to talk about that today. This area of research came really from an opportunity that was presented to me when the medical center decided to kind of rethink its relationship with the surrounding community. And that work began, really I think the most objective starting point was with the hiring of Michelle Obama, who had been working for the university and then came over to work in the medical center to run the first Office of Community Affairs for the medical center. So she was doing her work for a couple of years, building relationships with the surrounding community, really asking the question, if we wanted to build a healthcare system on the south side of Chicago, what would that look like? Who would be the players? There was no system of care. I think we're a little bit better off now than we were then, but there's really no one unified system of care in this region, which is a big region, 860,000 people, bigger than most cities in the United States. And she started to put her eye on a new job opportunity, which was to go to the White House, and she recruited Dr. Eric Whitaker, who took over. He was the director for the Illinois Department of Public Health, a graduate of Pritzker, and came back to take over her role. And when he came back, a window of opportunity opened, not just for me, but for other faculty who'd been doing their traditional research in their medical fields, but who were working on the south side of Chicago because we really had a passion about the possibilities of working in this community in particular. And I know for me, I had worked at the Friend Family Health Center, which is a community health center, and in the Student Health Center. I just felt like, for me, the best meaning I could get out of my practice of medicine was to offer the best quality care to people who might not be able to get it otherwise. And that's not my entire patient population, but it's always been part of my patient population. It makes me it's selfish. At the end of the day, I feel really good about my work when I know I'm applying my best talents and skills to people who otherwise might not get medical care at all. So that's how I got involved with the Urban Health Initiative, and it was really 2008, and I've put myself through my own dissertation, my own PhD program in urban health, and with a lot of humility and with a great deal of partnership from a whole range of people inside the university I've never met before then, and with a whole range of people in the community, in the surrounding community. And there's tremendous talent. What we've come to discover is the diversity of talent among the people who live and work in the surrounding organizations and institutions on the south side of Chicago. So we have to, such a small audience, but one of our key funders is the federal government, and we are required to include this slide whenever we present on this work, so we have now done that. And this slide just is most important. It shows you with some icons, and we've stolen IT services, and because you clearly have been a partner for a long time now. These are just not even all the entities we've been working with over the last 5 years, and groups that are involved in the work we're going to share with you today. So we wanted to start with just, Chris asked us to speak about kind of the use of mobile devices in research, and so we kind of decided to call it M Research. And we know that M and E are getting put in front of virtually every word, but that's what we thought was kind of the iteration of what we might talk about today. I said to Karen, did we just invent this term, or is somebody using this term? What did you find? When
Other people use it, but it's mostly in the corporate world. And nobody's really defined it. They use the term and assume that everybody understands what that means.
You even found a quote from Francis Collins.
Right, and so Francis Collins did open a conference recently talking about mobile research, not providing a lot of specifics, but talking about some of the new areas in which he sees research, mobile research specifically going.
Let's quickly introduce Karen.
I'm Karen Lee. I run operations for the work that you're going to hear about. I was an undergrad here studying history, philosophy, and social studies of science and medicine, but my master's background is in public health, really focused around health communication and health disparities. So what I'm really interested in here is sort of the complex problems for how do we really improve health, and not looking at one thing in isolation, but really trying to look at the whole system and figure out, how do we really figure out how to improve health.
So we thought if we had had a larger group, this probably would have worked better. But we thought about what is M research? When would you want to use mobile research versus other kinds of research methodologies to collect data? And so we could certainly open it up. But I wonder what your thoughts are on that. Is anyone else in the room using mobile research or seen other groups that are? Why would we use it? Why would we prioritize it or select it among the many range of options?
Well, from my perspective, with just the people that I've been talking to on campus, I think that it becomes compelling, especially in demographics that you guys hit, because there are more and more studies out that show that that is the device that people have. That is the computer. The computer is a mobile device that people have. So if there are ways to, use mobile devices to do research, on the one hand, I think that, that's a compelling argument. And the other argument is when you have to do research that requires you to be mobile, having a device that allows you to compute in a mobile way is also a good, it's a good tool to sort of have in your toolbox.
Yeah, and I think, I was just thinking this morning, well, I was listening to coverage this morning of the Boston stuff, right, like everybody else. But, one of the points that I think is coming up from that is, everybody's got these mobile devices and they are sensors, right, that are picking up lots of information from the world around us.
Right.
And, particularly in a health context, it can gather a lot of information sort of automatically without needing the intervention of someone to come around with a questionnaire.
Right. Absolutely. Any other thoughts?
I can just remember back in, well, I'm really old, but I can remember back in the days of time studies where you would go around and check people doing various things, and you read, or even in the pager days when this is just, as you said, so much more efficient because you can see if people are moving, what direction they're moving in, pick up, eventually correlate with environmental sensors. I mean, it's such rich data without having to do very much work. Once you get the permissions to access all of that, it just seems like it's a no-brainer.
Right.
Hi, I'm Megan. I work at the Polsky Center for Entrepreneurship upstairs, so I came just because so many of our students in the New Metro Challenge and the Mobile App Challenge are interested in this topic. I just wanted to hear more
You'll be
about
our conduit. We'll send you our slides.
Please do.
Yeah. And it's a great time to introduce yourself, too.
Sure. So I'm Leah. I'm working with a group with the Mobile App Challenge, and we're working on a healthcare application, so we're really interested in this sort of thing. One of the things that's really cool about mobile research from our perspective is kind of controlling for when you ask somebody a question, if you're not asking it to them in the moment, you're going to get a bias there, they're not going to give you the perfect information, or we can get better information by asking them while they're out there with their phone, living life. So,
yes, okay. So momentary sampling, daily diaries, there were these techniques, they were paper and pencil based. We would page people and then tell them to write something down, and this is kind of the methodologies that were being used pre-ubiquitous mobile devices. So thank you for sharing those ideas. I think we kind of had the same ideas that for in vivo data collection, people going about life in their regular life, it really works because everybody's carrying this device. Probably more people are carrying a phone than are carrying a pen and pencil at any given moment today. Mobility, when mobility is essential to data gathering, for example, the data you are gathering require you to walk from point A to point B, like the kind of data we're gathering, and Karen will talk about that. Or, say, actigraphy. We had watches. This is already outdated almost, a watch that people could wear that would count how many steps and whether they were sleeping or moving. But now the mobile devices can have that sort of sensor built right into the device. I think many of the other points that you all just made are here. I'll point out a couple that I think didn't come up. For us, the GPS functionality in a mobile device is quite helpful, and it has multiple benefits. For example, tracking our workforce. Where are our data collectors? Are they safe? Is the device safe? So keeping track of our equipment. And then also being able to passively geolocate data. So say we go to a storefront and we're entering information from what we see and observe at the same time through GPS, we can geocode or geolocate where we were. And both kinds of data can be collected. Longitude and latitude data, for example, can be collected at the same time. And then there's also the amazing capability for both qualitative and quantitative type data collection simultaneously with the same device, right? So imagine we are entering information about an address and a phone number, et cetera, for a place we're interested in, and we can also take a picture. And those data, plus the geolocating data, give us a very rich view of what's there, far beyond what we would get with paper and pencil. So those are ideas about what is research. So I mentioned the Urban Health Initiative, and the broad vision of the Urban Health Initiative is that the South Side of Chicago will be a model of excellence for urban health by 2025. And I'm going to show you some slides and pictures that will corroborate the notion that this is an ambitious idea. There are three main efforts within the Urban Health Initiative that align with the medical schools and the medical center's mission in the areas of patient care, education, research, and innovation. Karen and I work heavily in the research and innovation area, although we do look very proactively for education and training opportunities, and that's part of how we've gotten to know Chris, is we shared some interns last summer, for example, who helped us with our work. So this is the South Side of Chicago, demarcated in the dark black line. Some people have asked us, how did you get to this definition? It's 34 community areas out of 77. The definition came initially from the primary service area of the medical center, which is becoming an important regulatory definition under the Affordable Care Act, and even 501c3 tax code. Not-for-profit medical centers are being scrutinized and are being asked to demonstrate how it is they are meeting the population health needs of the primary service area that they serve. So there are a number of reasons why the definition looks like this, but it has high face validity. We've not had communities say, you have me in there and I'm not the South Side, or I am the South Side and you haven't included me. So it seems like this definition has worked. And you've had a minute just to look at some of the characteristics of the South Side population as compared to the city of Chicago and the United States as a whole. And I think if you just have a couple of minutes to scan that over, what you start to appreciate is that based on death rates, not health risk factors, because we have no data on health risk factors, but deaths, we see a disparity in terms of the number of deaths and the deaths due to specific kinds of conditions like cardiovascular disease and cancer. It's quite striking, whether you compare us to the rest of Chicago or to the U.S. as a whole. I think it's important, anyone going to school at the University of Chicago, living on the South Side of Chicago, I just think you have to know 50% of the households living at or below 200% federal poverty level. That's astounding. That's about $25,000 per year income. I mean, that's 430,000, probably, roughly speaking, households to people. It's a huge number. So then quickly, I just want to now paint the picture. We shared some of the demographics of the region, but paint the picture of the health facts. And I mentioned before, there just is no prospective population health monitoring system for the city of Chicago, including the South Side of Chicago, and this is true for most urban areas in our country. The federal government pays for population health assessments through the National Health and Nutrition Examination Survey that occur on an annual or semi-annual basis at the county level. And it's not the same county every time. So Maywood, Illinois has a trailer that comes, supported by the federal government, and they gather really good data, but they don't get more granular than the county level. And you can imagine, Cook County includes very wealthy suburbs and the South Side of Chicago, and we really can't generalize based on even what you see here. So we rely on vital statistics data, birth and death certificates. And those aren't the greatest sources of data, and they certainly don't tell us where we could be intervening to prevent badness. What they tell us is who's dead from diseases that were preventable. And so the dark red colors are generally the bad places to be for all of these slides. This is accident deaths, and you can see that actually that red strip, who knows what goes along that red strip? Pardon? Dan Ryan, right? Okay, makes sense. So we see north versus south here, disparity thanks to the highway in part. Prostate cancer deaths, this really highlights massive disparity between north and south sides.
Yeah, go back to that slide, the one where you suggested it's the Dan Ryan, because the Kennedy goes up through the north side.
Yes.
And it's not quite as dark.
Not quite as dark, no. We still see that. You can still kind of follow the Kennedy all the way, but you're right. It's the highway plus, right? All those other things. And then, and prostate cancer deaths actually looks pretty similar to accident deaths and homicide deaths as well. We see a hot spot on the west side where also the conditions, the sociodemographic conditions look very similar.
Why do you think there is difference in prostate cancer? Is it also associated with quality of life?
Is it also associated with quality of life?
Of life or?
Meaning exogenous factors, factors in the environment, et cetera. You know, I've sent that slide to the urologist at the medical center because of all the slides, that one showed the most stark disparity. I actually think that's an example of not having access to health care. Because prostate cancer is very common in the population, it's just that it is also, to some degree, preventable or preventable early. Those were not cases of prostate cancer, those were deaths due to prostate cancer. So in the higher income communities with better access to health care, men are less likely to die of prostate cancer. They outlive their prostate cancer. And then diabetes. And I just want to make one point about this community number 47 because it really helps you understand why we're doing what we're doing. That's that little triangle just above 50 and below 45. That's a community called Burnside. And it's a very small community with a small population, but it really lights up as having a disproportionately high death rate due to diabetes. And I showed this to our diabetes researchers and they said, well, but it's such a small community and so the estimates are probably, there's a lot of error in those estimates at the community level. So if you click, so based on our data collection, which has been focusing on assets in the community, what we find within 6 blocks of each other are 3 dialysis centers on the boundaries of this small, very small community. And I can tell you that dialysis centers, which are huge profit-making entities, do not locate in places that are inconvenient for people with renal failure. So to me, I just sent this slide today back to those researchers to say, are you sure you don't think there might be something to this hotspot in Burnside? But it just is an example of how layering data, information about the businesses in a community can help triangulate what we find from information from death certificate data. Both data sources might be imperfect, but when you start to layer them, you start to, be able to tell a story. And the free market, to some degree, when you're looking at for-profit parts of the economy, does tell you what's going on. So this is recent from the New Yorker, the caveman throwing the guy over the cliff because it's the only treatment option he has under his current health plan. And we would like to not be operating in, like cavemen on the south side of Chicago. What these cavemen said to this guy is, you have diabetes and you need to take insulin, and here's your prescription for that. But now you need to go because we need to move on to the next patient. And by the way, we yell as he falls off the cliff, you need to exercise and lose weight and see a podiatrist and get your eyes checked and all the other things that a person with diabetes has to do to survive. Insulin alone will not solve this guy's problem. And so this is a really nice metaphor for what we're trying to do, which is rather than throw people off a cliff when we give them a diagnosis and a drug, which doctors are good at doing. Doctors at the university, doctors in the community are all good at doing that. We are trying to connect that person to all the other dots in the community that allow him or her to manage with the diabetes, or maybe even prevent it from getting worse. So as we've been kind of developing these ideas, working with community partners, et cetera, and writing a proposal for the funding that supports the Community RX project, the Robert Wood Johnson Foundation does us a huge favor. December 2011, we're here at 4 o'clock in the morning for about a week in a row, writing a proposal to the Centers for Medicare and Medicaid, and this survey pops up. And this was a survey, a really well done, scientific, not M research survey, but actually they might have used an internet approach of primary care physicians in the United States, probabilistically sampled, asking them some questions about that falling off the cliff problem. And this is what we find, not surprisingly as a physician, physicians wish they could write prescriptions to help patients with their social needs. 1 out of every 7 prescriptions they write would be to do the podiatrist and the weight loss and the nutrition, et cetera. 4 in 5 physicians say patients' social needs are as important to address as their medical conditions. And this was even more true for physicians working in low-income urban communities like ours. And 4 in 5 physicians surveyed said they're not confident in their capacity to address their patients' social needs. One of our colleagues, Dorian Miller, says, I feel like I should have got a social work degree first and then my medical degree. And these are the kinds of things that if we had in place when we let our patients leave the clinic or the doctor's office, we could avoid them falling off that cliff. If we could connect them to a fitness program, nutritional food, transportation assistance, childcare, housing assistance. These are the kinds of, this has very high face validity from the perspective of a physician working in one of these communities. So this is where, so that came out, we're writing the proposal, and whether you are a business school student and have to write business plans, or you have to write a proposal to bring in funding for research, or to build a new technology, you know how important it is to have these kind of timely data. And so we took those findings and put them in paragraph 1 of our proposal to the Centers for Medicare and Medicaid. We proposed a concept called Community RX, which is a technology that is a web, well, essentially, I guess, using the internet, but much of the data that's driving the Community RX system is coming from the mobile devices that our scientists are using to collect community resource data. So I'm going to tell you quickly about the end product, what we are now delivering to people living on the south side of Chicago as a result of this funding, and Karen's going to tell you about MapScore, which is really the M research part of the talk. So the Centers for Medicare and Medicaid were looking for proposals that help them advance their mission to provide access to high quality care and improved health at lower cost. They are particularly concerned about the people whose health care is being paid for with your tax dollars, the Medicare and Medicaid recipients, but they were interested in innovations that would lift everybody up. And what we're coming to understand now, especially with the health reform legislation, is that most of us over the course of our life, maybe we won't all be on Medicaid, which is what provides for people, their children and living in poverty, people with disabilities. Maybe we won't all be on Medicaid. But a lot of us will move between private health insurance exchanges, employer-based health insurance, Medicare over the course of our lives. And so the more seamless we make that, the less dead weight loss there is in this, and waste there is in the system. So the Innovation Award, CMS had received $1 billion appropriation from the U.S. Senate or U.S. Congress in order to fund these innovation awards. And in the first round, they funded 107, 7 in Illinois, 2 at the University of Chicago. David Meltzer, who's a colleague of mine in the Department of Medicine, received an award that's less technology-based and more kind of based around comprehensive management of those hotspot patients, the ones who are really driving healthcare costs. And this is what they were looking for. They were especially looking for innovations that address people with the highest healthcare needs. And they really encouraged applications that were tailored or customized to the expressed needs and ideas from the community that was being served. And I think that's where we had a real strength, because we had been working with community organizations to develop everything we were doing. They were at the table, they were already engaged, and we made a very compelling case around that. So Healthy RX is being rolled out. This is our pioneer site at the Comed Home and Health Center on 43rd and Berkeley. It's a part of the Near North Health Services Corporation, which has sites all over the city of Chicago, north and west side as well. These are some of the characteristics of the patients who are seen at the Comed Health Center. And we've been working with this health center through several of our partners to deploy the new technology that is linking patients to all those places, programs, and services in their community they can use to be healthy. So this is an example of what the Healthy RX looks like. It's literally a printed, personalized health directory of places, programs, and services that complement the patient's health needs. It's generated in the background. So the physician is using an electronic health record during the doctor-patient visit. At the end of the visit, the physician has to close out of the chart. And when I close out of the chart, what happens is a printout right there in the exam room of a summary of the patient's visit and this healthy prescription. Now, we're hoping very soon the printout part goes away. We could imagine instead I close my chart and the patient gets a text message with a URL link, right? Or to some patient portal. But for right now, our patients don't have enough access to those resources. We're with paper. So we give them places that are tailored to them. This is all happening algorithmically in the background. So we've been developing ontologies that link patient problems and diagnoses in electronic health record to places, programs, services in the community. So the doctor and the patient don't have to waste their time doing that. And it spits out. Patients are given the information, a map. It's all centered on their home address. a connection to a community health information expert who's stationed in their community, not at the health center, not at the university, and an incentive if they want to call and give us feedback about whether they use the Healthy RX. So we launched this March 27th, and we have printed more than 1,000 of these Healthy RXs at the Coleman Home and Health Center in about 4 weeks' time. And these are the community health information experts. You can see the community organizations where they are deployed, and we'll be hiring 2 more of these individuals, training them at the Graham School here, which has started a new community health worker certificate course with us. And they are really important frontline, not just for servicing the needs of patients and people who want more information, but they also are going to start building relationships with the community-based service providers whose names are on those Healthy RXs, so they start to get information back about the kinds of referrals they're getting from whom and where.
Have you guys gotten much feedback from the Healthy RX?
From people calling in, much less than we would have expected.
Right.
And there are a number of, I think, levers that we can press to fix that. I asked the community health information experts, why do you think you haven't gotten too many phone calls? And one of them said, I think the information on the directory is pretty darn good and people are able to help themselves. Well, that would be a good thing, right? And so the community health information experts their job description might be less about direct to consumer relations and more the glue with the community-based service providers. So that's just part of what we're learning. That would be a good answer. That would be an optimistic answer to that question, right? The bad answer would be people don't trust us, people don't trust that these people have good information for them, people can't make a phone call. I mean, there could be a whole bunch of other reasons that would not be good. Okay, Karen's going to talk about MAPSCORE and the M research part that's driving all of this.
Okay, so how do we get to the point of being able to provide information about community resources to patients? Well, the first thing is we have to understand what's in the community. And, we have a lot of people ask, well, can't you just go to Google, go to Yelp? Can't you buy a list from, say, Dun & Bradstreet that's supposed to know all the businesses that are there? And the answer is, on the south side of Chicago, those sources aren't good enough. If you go to, I think we've tried Google Street View, if you pick a random block and you compare it to the data that we have, it's about 50% out of date. Dun & Bradstreet, I think the first year that we went out and had MAPSCORE, we used Dun & Bradstreet as a basis to start. And what the students were finding is that 30% of what they were finding in the community, not on the list, 30% of what was on the list, not in the community. So in order to provide accurate information to patients, we have to go out and do MAPSCORE. And because, if a patient gets information, they might call the first place. If the first place isn't there, how far down that list until they give up? Or they throw the thing away as like, this is not useful. So we have to, so the freshness of the data is really important in making sure that we know what's happening in the community. That gives us, trust from people. So MAPSCORE is really a partnership between teams here at the University of Chicago, the community. We have community-based service leaders and partners, and then we also have high school students that are working with us over the summer. And MAPSCORE stands for Meaningful, Active, Productive Science in Service to Community. So where does MAPSCORE happen? Basically we're hiring high school students over the summer, and they go out and they walk block by block, identifying all the businesses and organizations that are there. We started back in 2009 in the communities that are in yellow, and every year we go back, we update the communities, and then we expand. So what you see that's colored is now where we have been, which is the equivalent of 10 zip codes, about 20 communities. So we've really grown over 4 years.
It's actually 50 square miles, which is hard to picture. It's a really big area.
And these are our scientists. They are high school students that come from the community, predominantly sophomores, juniors, seniors. They come in, we give them training, classroom training for about a week, and then in-field training about how do you collect data. How do you make sure that what you're collecting is accurate, and what is the importance of that? So they are collecting information about every business and organization. And they are doing a census, right? So they are collecting very basic information about the places there. They're collecting the name of an organization, the address, phone number, website, so basic contact information, whatever they can get from the street level. And they're using smartphones and what we call map apps to collect the information. So the question is, why a mobile app? And we talked a little bit about M-Research at the outset, but for us, why did a mobile app make sense? So the first thing is, as I mentioned, we always start from somewhere. For a new community, we buy Dun & Bradstreet. Even though it's not the best data, it gives us some idea of what might be out there, and so they have an idea of when they're going out onto a block, how many places do they need to check? And it gives them an idea of which streets do we really need to pay attention to, because there's a lot of cases on this street. For communities where we're updating, obviously we use last year's data because it's better than Dun & Bradstreet. But because it's a lot of information, right now we have over 8,400 cases. So if you're doing it on paper, that's a lot of paper to flip through. And depending on how you might be searching for something, it's really hard. It would be really difficult to search for exactly what you're looking for. At least it would take a long time. So that was one reason, is to give them a tool that would easily allow them to flip through existing data. The second thing is reducing data entry time. If we collect on paper, we have to bring the paper back and somebody has to enter that into a system. So instead, they're out there on the street entering the data as they see it. Also, eliminating duplication. So we have, this year, we're going to have about 80 high school students out in the field. And so they're spread out all across the south side. So, and they're taking different paths. So how do they know that another team hasn't already covered that block? If you're doing it on paper, you have no idea. So you may be recovering a block that's already done. An efficient process for rechecks. So there are a lot of organizations where you may go to, say, a church on a weekday and not know if it's open or closed, right? So we have a process for people to be able to go back and recheck. Maybe somebody goes by, we do a lot of rechecks of churches on the weekends, because then we can see, are people coming and going? Because there are some where it's really difficult to tell whether it's open or closed. And then the last two things, why did we use mobile versus a laptop or a tablet? And it's really cost and reduced risk of theft. So, when we have 80 students, we don't give every student a phone, but there's one for every 2 students, so that's 40 devices that we would need to have for the field. And at that rate, phones are cheaper. And then the other thing is, there was a lot of concern about people being out with a tablet, right? And being very visible about what it is and having people come by and steal it. So we thought phones are much smaller, and so it's harder. You can always stick it in your pocket, stick it in your bag as you're walking around. We also are using Android and not Apple phones, because there has also been a lot of Apple phone theft, and so we're trying to keep the students as safe as possible. So what is MapApp? So what did we come up with? So because of the existing data, you're able to have the data organized by the block level, so that when a student goes out, they can pull up the exact block that they're on and know what to expect. As I mentioned, they collect basic contact information about a place. They classify each place for their main function. So even if you see a church and they have a food pantry, we would classify it as a church because that's its main function. We have another process where we go back to each of these organizations to try to understand what services are there, and that's how we get to, there's a food pantry at this church, or there's a community exercise room that people can use at the church. Map app allows you to continue work even if you have no network connection. So I think in the early years we did run into this problem. We had a very early version, not really an app, but a web-based application. And because it relied on the network, students would be out there and they're watching the circle go around and around and around. So we designed this in a way where even if you're not on the network, it's still functional so that you can keep moving and not have to wait for it to load. And then, sort of as we mentioned, it's tracking GPS coordinates and you can take pictures of places. And the GPS coordinates, you can imagine we're not there yet, but the idea is to be able to see how they're moving around in the community so we know where they are at all times and to also see what ground they've covered. We used to do this on paper, but sometimes people don't remember exactly where they were, and so we had a hard time figuring out whether a block was actually covered or not. So I'm going to take you through Map App a little bit. So, pretend that you're one of the students and you're walking down a street like this. So first you log in, then you select which community you're in. You can select the street that you're on and the block below. And then what you'll see is all of the cases that are on that block. So you pull up a case. So this would be, if you scroll down further, and you'll see like the basic contact information, right? Name, address. And then you have to make a, so we mark every place as not visited. This is another way that we are figuring out whether a block has been covered or not, is by marking everything as initially not visited, so that you have to go into every single case and mark it as okay, and that means it's up and operational, it's gone, it closed, or you're not sure. And this is where we have a lot of those churches during the weekday where you're not sure. We try to train the students to be detectives, sort of look for, talk to people, see whether they know whether people have come in during the weekend, look to see if there's mail piling up, that might give you a clue, things like that. And then, I think this is pretty much private residences. So Dun & Bradstreet, because their list covers every business that's supposed to be out there, there's a lot that are in private residences. And so we try to track anything that we can that has a sign. So you might see like home daycare, right? That would be a service that we would be interested in. But there are others where it might be somebody, created a business in order to hire a housekeeper or something like that. And so those we're not interested in. So those we keep private and we don't post them to our website. So as I mentioned, the other problem that we were trying to solve is, knowing where they are in the community. And our students walk about 4.5 miles a day. I think not the first year, but the second year, we wanted to know how far they were walking. So we gave them pedometers to try to track that. But, pedometers aren't really a good measure. What the number of steps that I take for a certain distance is different from probably the number of steps that you take. And, we really have to sort of make an estimate for how to translate that into miles. So that's another reason for the GPS. We did try Google My Tracks. There is an app out there that would, sort of collect your GPS data and show you what distance you've traveled. So we did try that one year, and then we decided, if we're doing this, instead of trying to run two apps, why not just build it into the app that we've created? So we're not at the point of being able to display it on a map, but we are collecting the GPS data every few seconds. So all of the data that the students collect goes up on southsidehelp.org. This was our initial website for how to get the information back to the community. And we try to do that really quickly within a couple months of finishing data collection. So after the students collect the data, we do clean it just to make sure that the information is as accurate and reliable as possible. And this was sort of a way to let people interact with the data and hopefully find at least some of the places that are available. But as I mentioned, now we're going back to all 8,400 places that we have and trying to understand what are the services being provided there. And that's how we get to HealthyRx, so that we can more proactively provide people with information about community services. This is also in Spanish, dondeesta.org.
Want me to finish?
Yeah, because I don't know what you.
I don't know.
If
Well, I
you
think
had
this,
something
these are
specific.
just two places actually that pop up very frequently on the HealthyRx being distributed at the CoMed Health Center, because they're both within about a 10-block radius of that health center. And many of the patients, I mentioned before that the ontologies link patient diagnoses to the place's programs and services. And if you imagine what those, what those common problems are, obesity, diabetes, wellness, almost all of them call on physical fitness and other kinds of programming that are offered by organizations like Weight Watchers and the Southside YMCA. So one of our next, as I mentioned before, one of our next challenges is to think about how we will take the data we're collecting, both through the mobile application and through the Community RX system, and translate it back for the use of the community-based service providers and for policymakers. I can't think of a way Jennifer Hudson herself, maybe, I don't know, she's a Southsider, maybe she's looking for a place to have dinner when she comes back. But how do we take the data and move beyond just kind of delivering them through the doctor-patient relationship or in a more passive way on the website, and really use them to drive the kinds of services that places are offering in the community. And I think the next slide best represents the kind of the core hypothesis of HealthyRx, which is that there are many good reasons to motivate individual health, but the accumulation of individual health is community health. And we're really interested in whether we might have a new lever here for motivating health. And the conversation in the doctor-patient encounters could be something like this. Here, according to the problems we talked about today, here are some places, programs, and services in your neighborhood that I recommend you use for good health. And even if you're not motivated to do that for yourself, these businesses are vital to your community. Go to the YMCA and support them, because they're there offering jobs and services for the kids and older people in your neighborhood. We're really interested, that idea didn't come from us, that idea came from the strong voice from community partners who really are motivated around anything that advances community development. If health is good for community development, then they're in. If health is just about health, well, it's a kind of secondary importance when you think about the poverty levels and the joblessness, et cetera. So over time, we hope to learn whether that's the case, whether we can motivate individual people to be healthier because they believe that those behaviors will help sustain the tax base and the programs and services in their neighborhoods and make them more attractive and vital places to live. So that's the end of our formal presentation, but we have a few more minutes if there are questions or you have ideas for us we should consider.
This is awesome. This is so cool.
Thank you.
I'm curious, back in the beginning of the presentation, you talked about the healthcare law.
Yeah.
And so, I hear lots of different things from lots of different people about this. And I wonder, just from my role, I wonder how will technology, including technologies like this, mobile technologies that are used for research but are also used for the actual patient experience, how do you guys see those playing into how hospitals or clinics or physicians individually respond to that legislation? Do you see that playing a role?
I do. I mean, I think it's a very big question. Let me just respond with a couple facts. First of all, the first meaningful expression of health reform legislation, in my view, was the incentivization to adopt electronic health record systems. So 5 years ago, my practice at the University of Chicago, 3 years ago, was not electronic. It was paper-based. There was a major incentive, a financial incentive per physician who adopted for people to get on board, and very soon the switch is going to go off and the carrot becomes a stick. So the fact of getting the United States healthcare system into the 21st century is a huge economic force that meets the needs of regulators, because the way we are managing our patients becomes much more quantifiable and much more transparent. I think it's one of the reasons physicians have opposed it. We have terrible handwriting for a reason. If you scribble, nobody knows what you really said or did in a court of law, right? So the fact of electronic health record adoption is going to have huge influence on our ability to evaluate how doctors and medical systems are providing care, and to, in the best case scenario, feed that information back in the form of biofeedback so we can do better and get the benefit of knowing we're doing better real time. And that's healthcare informatics. What has not happened on the flip side of that piece is that the whole rest of the healthcare, the whole rest of the system, the guy falling off the cliff, the YMCAs and the Weight Watchers and the community counseling centers and all the other organizations that are largely operating with taxpayer money, philanthropic dollars, are not accountable for the services they are supposed to be providing. There's no transparency. We don't know how many people are being served. We don't know whether people are getting evidence-based care or getting better. And I think that the next big emphasis needs to be bringing all those other kinds of service providers, just even think dentists and podiatrists, optometrists, into the system. And so that really nobody's talking about that, and people look at me like I'm crazy when I do talk about it. And there's the feeling of like these poor organizations are just struggling to make ends meet. They could never possibly put information into a computer. It's the same thing we heard from doctors, 10 years ago. That's one big trend. There's a huge push in the regulations around meaningful use of health information. And it's largely focusing on the electronic health records. And what that means is, okay, doctors, it's not enough to just collect electronic health record information. You've got to be meaningfully using it to improve your patient's health. And there are a whole variety of ways doctors and healthcare groups can meet that obligation. There's a lot of emphasis on direct-to-consumer functionalities that take the information from an individual's patient's record and feed it back to the individual patient so that they can make use of it. I would say that HealthyRx falls in somewhere in that space. We think it's an important, we think meaningful use is an important opportunity for what we're doing. And the degree to which over time our next versions can get closer and closer to the consumer and even allow the consumer to generate their own HealthyRx outside of the electronic health record will, I think, really measurably impact how we grow and scale what we're doing. The responsibility for population health, this community benefit requirement that you may be hearing about, Chris, in the ACA legislation. It's both in the ACA and in 501c3 regulations. There is opportunity from the federal government sees opportunity in or real return on investment in scrutinizing highly large revenue-generating 501c3 organizations, and hospitals are prime targets for that, to know whether that tax break is actually being reinvested in a way that measurably impacts the taxpayers. So how do we always reinvest our tax breaks? Brand new, beautiful buildings. And everybody's still doing it. But if your brand new, beautiful building only serves a fraction of the population in your primary service area, you're probably no longer meeting that requirement. And so part of what those regulations are doing, and some organizations are taking this much more, I think are taking a much more sincere approach than others, and that's the free market. Some are doing the bare minimum to demonstrate that they're using their tax breaks for community benefit, and others are really taking opportunities, and I think we're an example of that, to innovate with the population, find out what the needs are, and in our case, people just needed basic information, not just patients, but other important organizations that they can use to sustain their missions. That's a long-winded answer. It's not even a complete answer, but just some of the big areas of trend I see in the legislation.
Stacey, you talked a little bit about issues of trust in the community, and I think one of the things that technology.
Thank you guys. I'm sorry.
It's
nice to meet you.
Not just mobile technology, but the whole explosion of the internet has really made possible is people talking to each other, right, instead of just us talking to them.
Right.
We want to know the community. It strikes me that there's, as this gets more rolled out in the community, there's going to be a role for that for people that, who've used the Healthy RX places to say, I use this place and it was great, or I use this place and
Right.
it had some problems, and inform each other, right?
Yes.
Which is, people tend to trust a lot more than hearing it from an authority figure.
Right, yeah, do you want to speak to that?
Yeah, I mean, I think a lot of people have asked about, with Yelp out there, right, and sort of reviews of places, Amazon, the same thing, right? How do you get at the quality of community services? I think it's not easy, and I think we haven't quite figured it out yet. But obviously, it is really important because we want to make sure that we are, if we're looking at places that do provide care in an evidence-based manner, we want to make sure that we're sending people to those types of places as opposed to organizations that are not, right? So right now, it's just, we're trying to figure out everything that's out there, and then I think we will probably add another layer to try to get at that issue.
The way that some organizations have handled this, there's a program called the Illinois Statewide Providers Database, which, and the woman who created that program for the Illinois Department of Children and Family Services is a consultant on this project and a faculty member at Northwestern. They have used, because their programs and services are largely focused around those that kids in the juvenile justice system would need to access, and a lot of these providers are kind of certified providers, they have a series of questions to assess whether or not the organization is providing evidence-based services. And there is an evidence base in some of these cases that against which those organizations can be measured. But how do we apply that, let's say, to a gas station that has free Wi-Fi on the south side? Well, we want people to know where they can get free Wi-Fi. People really need that to do a lot of the other things we want them to be able to do. But the concept of evidence-based practices around that is not entirely clear.
Or quality. Right.
Or quality, like,
I mean,
is it
right, the
good
Wi-Fi at the
connection,
gas
or you gotta
station
get-
versus the Wi-Fi at the library
Right.
versus the library at an internet cafe. Like, how would we figure out, what is quality or not quality? The same thing with food, right? If we talk about, where can people get, healthy food? Well, what do we use to measure that? And then how does cost figure into it, right? Because for our populations especially, yes, we want people to be, we want to get people to services that can help them improve health, but some of those have out-of-pocket costs, and which are, in some cases not low. So how do we find the right mix of services that, can get people what they need, but also at a price that they can afford?
So I think the crowdsourcing of feed quality and feedback, et cetera, is a suggestion that many people have made. And at the moment, there's not a feature in our system that would allow people to weigh in with those kind of comments at the organization level. The way we would be gathering those right now is through the community health information experts. So the Healthy RX actually says, we want to hear your feedback and your experience. So that information would come into our community health information expert. It would go into their database. They'd be able to use it in their counseling, but it wouldn't go direct to consumer. One of the obvious problems is, transparency is for sure the way to go, and we just have to figure out how to get from here to there. One of the problems is, obviously, some organizations are going to look really bad,
Yeah.
right?
Right.
Well, that's good knowledge. It's good knowledge for anybody who might want to use a place, or for the people who might want to improve their service, right? So we have to get there. And the other missing piece for us is, how do we know that a patient or who got referral actually showed up at the YMCA?
Right.
And the providers want to know. They want to know from the YMCA that the patient went or didn't go. You can imagine what kind of capital investment would need to be made to get organizations like the YMCA online, unless there's a policy innovation like we had with electronic health records. There's a carrot at first that says to all the health and human services organizations, we'll pay you $20,000 if you get your systems online, and after a few years there's a stick. And we are starting to look into, I've been looking for a graduate student actually to help me research the possibility that we might have to actually create legislation to address that issue, policy to address that issue. So,
Yeah,
if you know any, send them my way.
Huge, for sure.
Well, thank you so much.
Well,
This
thank
was
you for doing
intimate,
this.
but
Yeah, it was an
thank you.
intimate setting, but I appreciate you
okay.
guys coming. I appreciate you guys taking the time to do this.
It's our pleasure. Thanks for the invitation and for your partnership.
Oh, well.
I think it's
we're
good that your
happy
boss
do
got
it.
to see how you're
Yes.
spending your time.
I know how you're spending your time.
We talk a lot about this stuff.
Okay, good.
So,
All right.
thank you guys.
Did you have any other question?
You know, I actually, I work with health aides, and so I've worked with Southside Health for a couple of years, and I've never really understood, because I think we interact with a different side of it,
Yeah.
right? And I have to log in, and we do have reviews of the different
Yes.
organizations. I've never really understood why patients don't have access to that, and
Yeah.
I haven't explored your side of it, so I
Yeah.
don't know if they secretly do.
Oh,
But
Yeah.
so yeah, like why isn't there that? Like why are you like have that piece kind of set aside?
that technology, our group have developed that technology for health leads according to their specifications.
And so we ask for it kind of to be sequestered.
Yes.
That's
Well,
what
yes. I don't know. I can't say. I don't want to speak out of turn. I can't say that health leads asked for it to be sequestered, but health leads did ask for it to be password protected, and has not asked, to our knowledge, for it to be liberated to the public view.
Mhm.
I think part of it is because it's really built more as like a case management type of system.
Mhm.
Because there are a lot of notes like call this person, ask
Right,
for
which
this
is like
person.
still information that we give to clients. So,
Yes.
like I can see instances of that, but it's always been like this is a good opportunity to give this to somebody, and so
Yes.
that's confused me for some
Yes.
time.
I think you should ask. I think you should ask that question to Cody. I think health leads would face the same challenge we do, which is the erosion of relationships potentially. So you guys form relationships with Joni at YMCA, and it's a one-to-one relationship, and she's helping you navigate the system. But once Joni YMCA sees her name publicly on the website, and everybody starts calling Joni, then you kind of erode that. So how do we crowdsource or facilitate consumer participation and experience rating in a way that supports those relationships, doesn't potentially overwhelm them or erode them? And I think that is a challenge we have not yet figured out.
I think you actually are doing this, it's just on a more long-term basis. The thing that I'm most sanguine about this whole program, in a way, is that you're empowering 15-year-olds to do this. And I mean, wouldn't the hope be that in 15 years it will all be on Yelp? Because these kids will figure out, oh no, I know how to go straight for this. This guy was mean to me. I'm not going to put it on there. I loved this person at this drugstore. They gave me the exact information. And it is training a whole generation of people to embrace the things that we think, that our kids do automatically, because they've been exposed to it since the get-go. And it will integrate the systems, like, that eventually health leads, this stuff, Yelp, will all be part of the same, in a way, network.
Right.
And that should be our goal, is to make that for everyone. But
We have talked about putting just the Yelp link, but
right.
then which rating link do you choose? Every time you pop up a balloon for a place, if you had the hyperlink, sorry, we're finishing up. If you had the hyperlink to existing ratings wherever they existed, and if they don't exist, it could just come up saying there are no ratings. Here are some suggested places to go to rate. So it's outside of our system.
Yeah, right, so it's not, you don't shoulder the praise or the blame.
Right.
Right.
We just are the connection.
Yeah.
But it's probably also premature too, because some of the best organizations that you guys operate with are not necessarily going to have a presence there, and then they'll get blown out of the water.
Right.
I mean, it is just premature at this point, but it is the goal kind of to see
Right.
10, 15 years from now, in 2025,
Right.
everything
It
will
could
be on
even just
Yelp.
be the like thing.
Facebook like.
Yeah.
But, I think for you guys, the big question is always going to be, what are the integration points, and how do you share your data, and how do you encourage people to share
Their
new bits of data, right? The experiences that they have had from your data to share it elsewhere.
Yeah.
People are doing that already, and they're going to do it more and more. The question, I think, for you is, how do you encourage that behavior in a directed way?
Yeah.
Because the reality is, if you leave everyone to their own devices, you're gonna get scattered distribution of, some are gonna put it on Yelp and some are gonna do it on Twitter. But if you can encourage people to do it in a particular way, then that data can then be recultivated by you. Right?
Yeah.
So if you push them to Facebook, or if you push them to Twitter or whatever, you can then recapture some of that data,
Right,
and then
right.
share some of that data. And really, then it becomes more a question of, I think we talked a little bit about this before, but it becomes more a question of what's the framework that you're building, because the data itself becomes less your business model. It
Yeah.
becomes less your IP than does the framework that you build to encourage the creation of that data and
Right.
the use of that.
And the linkages, I mean, I think that, right, the real, what we're building is the connectivity between a really important source of referral
Mhm.
and incentive, so to speak,
Right, right.
and these data. So it's the
Right.
API piece rather than the data. Although right
Right.
now, we could not operate this system without being the primary collectors of these data,
Mhm.
right? I
Right.
mean, and so this is why we you know, as we think about scaling to other sites, it either needs to be a deployment of a MapScore type team
Mhm.
or some other way that doesn't employ high school students to gather the data primarily. But we have
Right.
no indication that Baltimore, Detroit, or New Haven looks any better, Boston, than south side of Chicago.
Right.
Have you guys
So
talked at all to Google or Dun & Bradstreet about?
I have never once given this
absorbing your
talk. I
data?
have never once given this talk without somebody asking that question. We published a paper in the Journal of Urban Health that compared our data to Dun & Bradstreet and didn't make Dun & Bradstreet look so good. Fortunately, nobody's called looking for our head. We were extremely careful, obviously, in our analysis, et cetera. So I don't know if they've seen it, they know it's out there or not. Google, I've been carrying John Tolva's, John Tolva, who's at the city, gave me his card with the phone number to, I think, Brian Fitzpatrick, who's one of the principals at Google Chicago. And I've been carrying it around for 2 years. I really think we're at a point where we ought to have a serious conversation with Google, and it needs to be facilitated by the university, which owns the IP. And it needs to happen under a certain kind of, you know, whether it's a confidentiality agreement, and Google may not be willing to do that. But I think it would be stupid of us to walk into Google and tell them this whole story without some structure around that conversation.
Right.
So I really think we're at the point now, especially with the government funding, the CMS funding, because between the University of Chicago and CMS, and there's a little bit more accountability in a conversation like that than it was when we were just ourselves. I think now is a good time for us to have that conversation, and you know, Elise is sitting here.
No,
I have to figure out how to fit that in with the other priorities the university has in its interactions with Google.
Yeah, I am in agreement with Stacy. I actually think it's probably getting to the time.
Well, and to think that, I mean, the notion that just Google having the data does what you're doing
Yeah.
is silly. It's
Right.
totally silly. I mean,
Right.
because what you guys are building is, you're building a framework. I mean,
Right.
I know that I sort of harp on that all the time. That you're building a framework, and that's just the data piece. And
Yeah.
so, you know, if Google can be feet on the ground to help get the data that you need, and
Yeah.
then that can generate interest in Baltimore or in, you know,
Or if
New York
Google
or
just
wherever
simply
else.
fund the MapScore program
Right.
in, you know, 10 cities,
Right.
they can get the data and use it for however the heck they want.
Right, and then you've got your particular way that you're using
And
that
we
data.
use the data to drive a system that reduces healthcare costs. It does seem like a win-win conversation, and I just think it's time.
And more importantly, I mean, Google's got to be looking at workforce too. I mean, when you know what the
Right,
salaries
this is a
are,
pipeline
they
program
just
for the
do
kids.
not have the boots on the ground that they need to do any kind of work they want.
Right.
And these kids are, Karen and I talked about this yesterday, these kids are an untapped resource.
Yes, and you know, we would like them to not fall off the cliff after MapScore.
Yeah.
So, I don't know, help us think about that. I don't know if Farah can help us think about it, or
Yeah.
development, but I think it should happen soon. I kind of feel like we're at the right moment.
We might be able to help.